we'll be doing a workshop today with you about decision aids, which are tools about how to provide, or tools that we hope when we use them that they are enabling us to provide care that fits for patients. And there are two types of decision aids, which we will go into a little bit later. And then following that, there'll be a workshop where you get to work with your colleagues and do a hands-on demonstration. And I'll first present a little bit on the evidence that we have of decision aids. So what do we know about them? What we hope that they do some good things, that they increase the things we want and decrease other things that we don't want to see. And so to start with, I'll tell you a little bit about one Cochrane review that was conducted in 2017. If you could go forward, thank you. And so this is one of the most widely cited Cochrane reviews to date. It's a pretty large study for decision aids. It's a review of 105 clinical trials of decision aids compared to usual care or another type of intervention, and it represents over 30,000 participants in total. And we found it decreased some things that we were hoping. We hope that decision aids decrease, including feeling uninformed, which is what the funnel plot here shows you. This was measured using a subscale of the decisional conflict scale, which is often used to look at the impact of decision aids. And the review also found that the proportion of patients who remain undecided after use of the tools decreased, which is also something we hope these tools can achieve. Next slide, please. The review also found that compared to usual care, it increased some of the things that we hope these tools increase, including patient knowledge, patient involvement in decision-making, the proportion of patients with accurate risk perceptions about the risks that they're facing in their particular decision context, and then congruency between informed values and care choice. So for example, a patient who is diagnosed with cancer and who really wants to maximize their length of life, not necessarily prioritizing their quality, would have a decision that's congruent with their values if they chose life-saving treatments that may have significant side effects. And then the review also found that effective patient-clinician communication was increased, and that patients were more satisfied with their decision and the decision-making process. Next slide. So we see that there are a lot of good things that these tools do, and then there are a few things that there's not significant evidence on, and that this review and a couple other reviews have showed that we're uncertain about the impact of these tools in terms of the effect that they may have on adherence to treatment. And in the example that we will give you, it's a tool, we will look at tools around atrial fibrillation. And so the idea that patients who are at risk for stroke are taking their medication is something that in certain circumstances we really like to see, and yet we haven't been able to show that with these kinds of tools. Also, while some aspects of patient-clinician communication appear to be improved, the reviews have found, or some authors have found, that there's concern over the impact of tools, particularly those that are intended to be used by a clinician in the visit, of what that may have on the process of providing care. In addition, the impact of cost of patient care is uncertain, and then length of consultation. There's been some studies showing that there's no difference, and then there's just variable data on that, but no data to show that there really is an increase, which some people do have concerns about.
Okay, so well, thanks for participating in the activity. We have some questions that you have in the back of your handouts, or the second page of your handouts. So we have 12 minutes for a group discussion. We have some suggested questions. We can discuss other things as well. But generally, we would like to hear from the observers of each group. What were your general thoughts and impressions? What worked well and what didn't work well? Do you think that it helped the patients in their decision-making process? Was the PDA or the EDA effective, and how did it change the conversation? And do you think that these tools improve patient-centered care, and if so, in what way? So who would like to start? Let's start with the online group.
I can go first. Hey everyone, I'm Mike Gianfrido. I'm from Duquesne University, but did my PhD in Victor's lab, and I observed Kathy as our clinician and Ruth as the patient, and Kathy did a wonderful job. And I think the tool overall worked really well to help drive and focus the conversation, and I believe it did help the patient in their decision-making process by bringing up, and this was noted specifically, that those issues that were brought up, helped, but it also helped showing, what that risk was. And for our particular patient, that risk was not very scary or driving them towards action. And then that was only confirmed when they saw, oh, this is not a benign intervention, right? This has those issues associated with it. I think that it did help the clinician engage the patient in conversation, and through that engagement and conversation, I think it can improve patient-centered care by first of all bringing it up instead of just saying, well, you've got AFib, we're putting you on anticoagulants, and that's the end of it, right? By having the information there, and I wouldn't say forcing them to engage in it, but giving them an opportunity to engage in it, right? It can create a much different conversation than if it wasn't there. So those are my reflections. I don't know if Kathy or Ruth have anything they want to add.
I think the patient liked having the handout as well at the end to refer to.
Yes, that was great. And I also thought, sorry, you're not seeing me because I'm in bed. It's 4:45 for me in the morning now for me. And I think the visuals of it were really nice. And we were talking about how sort of, in terms of someone with maybe low health literacy, that would actually be really quite effective, as, being able to sort of visualize it rather than having to deal with numbers.
For us, we tried to really rush things so we could use both tools, and we were able to do so. And I think, well, they both work good in their purpose. Like the first one, that it's more for patients, I think it gives them clarity of what they can ask and what's important to them. And also it can raise questions that maybe were not in their minds prior to using the tool. And with the other one, that it's with the help of the clinician, I think it's very useful, as Kathy mentioned, having the report at the end, because maybe you forget things. It's so many things. And I also really like the cost information, because we've talked about it in previous meetings about how it's awkward to discuss cost and financing treatments. So that's something that the patient can see and start thinking about itself without having maybe to ask. And sometimes clinicians don't even know the cost of the treatment. So having the cost there, I think it was a really bright idea, an important one. And I just have a question, like, because we were doing this activity and we saw like the risk was so low, and the clinician, like, it's you think about what would you choose. So how you make your personal choice not to influence. Yeah, like when clinicians see the risk, how can they refrain from their own personal choices?
Well, I've been working in this project, and what I've seen is that the case that we presented to you is a very usual one. It's the risk is very low, and so the path is not obvious, because when patients have a higher score, then basically clinicians need to say you have to be anticoagulated. Of course, they may consider the options and understand what the patient is going through, but it's difficult to say, well, if you don't want, let's not take it. It's way more difficult for them. But in the cases of low risk, the conversations are very interesting, because there are patients that say, you know what, I'm so afraid of having a stroke. So I know I can have a risk of bleeding and maybe I shouldn't take it, but I'm so worried of having a stroke because my mom had a stroke that it's okay. I'll just take an anticoagulator. So the thing is that clinicians in general take a role of listening to the patient and accepting whatever, or well, what they want to do, particularly in those situations where it's not straightforward what should be done. So, but it is a great question. It's not easy to know what to do and not to let themselves be biased as to one or the other. So.
Yeah, and that in fact was like a barrier identified in the evidence. And so one of the what the encounter decision layers are useful because they help clinicians also know what matters for the patients most. So as you were saying, maybe there's they are more biased, or that let's say they are more declined for one option versus the other, but then going over all those different aspects that influence the patient, make them also consider those values and preferences and incorporate it into the decision. So therefore, even though the issue and recommendation is a recommendation based on what the patient's preferences are, rather than their own kind of perception of what to do. Because it's good to also patients need a recommendation from the clinicians. It's not that you cannot say, oh, it's all up to you, because in fact that gives anxiety to the patient and have like a high way of responsibility. But the clinician feels more comfortable issuing a recommendation based on those concerns by the patient, not on what they think clinically would be more adequate for that patient.
I think we know it's evidence-based medicine, but it's also, I think, eminence-based medicine, which means I just asked Victor what to do. And then there's emotional-based medicine, which I think is actually most of it. And I think you alluded to that there's going to be anxiety in any of these. And it's in our group, I felt the anxiety being the clinician. As someone said, I think it is much harder not to prescribe a medication than it is to prescribe one. It takes a lot more conversation and energy and engagement than to say something like urgent care follow-ups that I see, or a post-procedure, an AFib was noted. Go see your primary, you have to be on an anticoagulant. Step one is saying, well, that statement is just not true. You do not have to be on an anticoagulant. And let's talk about that. And it's very easy to quickly tell those people that don't want to take the risk and those people that want to take any risk because of the emotional base. I don't care what the number is, lowers my risk of a stroke. I don't care if my risk of a stroke is 1%, I want to lower it. So I think that dynamic, I think it's important to appreciate that there isn't one dynamic, that there are multiple ones, people that are risk takers, people that are risk averse, and there are people with a great deal of uncertainty in between this.
I do use a decision aid in discussing transplantation and dialysis and the outcomes for transplant listing. But I suppose where I feel there's an evidence base for that, an area where I don't have a decision aid to be able to use is an area where you still have to potentially do operations on patients where the evidence base isn't as high level as like that for use of warfarin in atrial fibrillation. And I suppose my question comes to, we still have to make decisions, we still have to help patients make decisions, but how do we do that whenever we don't yet have the highest quality evidence base?
Would Victor or Ian would like to answer those questions? Or Casey, they are the experts.
It's interesting because I live with multiple conditions that have really terrible evidence base. I don't know if it's a blessing or a curse that I know how to look up all the different treatment options and try to sort through them. But when you really look at the underlying evidence for many of the conditions that people live with, it's really awful. And I think part of it is, I do think in some cases creating decision aids or working on them can be useful, but I think you have a really good point. And I don't know the right answer, but I wonder if there's something like an ICANN activity or a set of key questions that you can at least understand what is important to the person that I'm talking with in their lives, and how can I present what evidence I know in such a way that makes sense to them, given what is important to them. I think that's one alternative. Victor and Ian can certainly weigh in on that as well.
Yeah, I obviously know the right answer to this question, which is that the purpose of shared decision making, and these decision aids ideally are there to support that process, is not to transfer information, right? And it's also not to translate evidence into practice. I'm going back to the talk earlier this morning from Marlene as to what is the problem that shared decision making is trying to address. And the problem she suggests is the idea of making care fit and maximally support people's priorities and goals, advance their situation, and minimally disrupt their lives and their loves. So if we think of those are the goals, how are these tools that help those conversations going to advance those goals? One, but not the only, but one of the objectives might be to summarize the available evidence insofar as that evidence supports using that evidence supports the process of making care fit. But there are other things that you can draw from that are not research evidence to achieve that goal. And so Casey suggested identifying, for instance, those goals and priorities. What matters to you? What is important in your life? What is getting in the way of your improvement, and so forth. So I think we should stop seeing these decision aids as simply tools that provide summaries of the evidence that are only available in situations where the evidence is available and summarizable, to expand to the notion that these are tools that support a process that in turn is there not to simply bring the evidence into the consultation, but in advancing the patient situation. So our own group, I think, has focused historically on summarizing evidence in our tools, but with, again, more recently, with the intention of simply creating conversations in which patients and clinicians can think about the way forward. And we now have the shared decision-making tools that do not summarize the evidence about the alternatives, but for instance, indicate that alternatives exist in a continuum of prognosis over time, like we're doing for patients facing the possibility of needing dialysis and renal failure. So, Ian, you can expand on, and tomorrow we're going to have a session on purposeful SEM, where I think there will be some discussion about what kind of aids, broadly speaking, can be brought to bear depending on the purpose of the shared decision making. Right? Do you want to add something?
Sure. So I think I'm going to end up repeating a lot of what Victor said, but the broad stance I think that I try to keep in mind as I work in this area is that you're absolutely right, Karen, that what's happening is that there's something wrong and you and your patient are trying to figure out what to do. And you're going to do that whether the evidence is there or not.
Yeah.
And so we can't throw up our hands and say, well, we don't have the evidence. Sorry, you're just going to have to sit over there and die. You're going to do something. And what that brings to mind is that the evidence is just a resource to draw on. And if it helps, it helps. And if it doesn't help, then it's the wrong resource. And the same with the decision aid, the same with different conceptions of shared decision making. All these things have a role, but their role primarily is to help the patient in their situation. And that's the same role you have as a clinician. And so we shouldn't fetishize these devices. We shouldn't fetishize the decision aid, the graphics, and we shouldn't fetishize the evidence. And we should just let it take its place in as much as it helps and let it go when it doesn't.
Yeah, it's helpful. Thank you.
Really got the full answer, Karen.
Thank you for the comments. Anyone else that would like to? So Zoe, did you have your hand raised or yes?
No, I've got to follow Ian and Victor, so that's why I put my hand down. Well, just to say, kind of along the same lines, I suppose, that we've developed a decision tool in osteoporosis in the UK for nurses to use in a fracture prevention clinic. And they were really negative about it, and they didn't want to use it, and they didn't think it would add to their practice. And the tool itself includes lots of different elements, just to lead on from kind of what Ian and Victor were saying. So there is some evidence in it, and we found the evidence very difficult to summarize, and in the end made some best guesses with expert consensus on what numbers to put in. But more than the evidence, there's other aspects to it. So doesn't really focus on discussing pros and cons of alternatives. It's really thinking about, I guess, purposeful shared decision making in its broadest sense. So the tool's got prompts on it that encourages the clinician to ask the patient about what they already think and know, and that's a big part of the tool, actually. So it's not just focused on information giving, it's more on eliciting as well. And it also includes animations and things about what happens to your body when you have osteoporosis and how your spine can change shape things. Because we felt that one of the things that was missing in conversations, and it kind of links to, this is about giving information, but it's about helping patients to know what matters. They can't know whether protecting their spine is important to them if they don't know what the consequences to their spine might be. So actually visualizing it was a helpful thing. And in the end, these nurses who were incredibly negative about a decision tool that they didn't want to use found that the tool solved a problem for them, and it solved a problem in helping them communicate what the impact of osteoporosis was. And so when they realized that, they started using it, and they used it all the time. So I think that because the original question we had was about barriers to implementation and things. So I suppose it's just thinking much more broadly about, what coming back to what Marlene said at the beginning, what's the problem we're trying to solve? And often there's numerous different problems from numerous different people's perspectives. But yeah, that was just all I was going to share.
Thank you, Zoe. Anyone else before we move forward? Okay. So finally, we have 4 takeaway messages. So as we have said today, several conditions may be necessary for successful implementation, including good quality decision aids that meet the needs of the patients, clinicians willing to use decision aids in their practice, effective systems for implementing decision aids, and proactively seeking opportunities to practice their decision making. The use of decision aids will not occur without adequate attention to implementation barriers and careful design of effective strategies for introducing and maintaining their use in routine clinical practice. So that's our presentation. Thank you so much for being here and for your questions. It has been a very interesting conversation. I hope you learned how to use or now you have a better idea of how decision aids look and how you can use them. So I don't know, Elissa, do you have any final comments?
No, I thought it's wonderful to observe all of you online with your different groups. Thank you for that opportunity.